Okay, thank you so much. My name is Ravina Tan. I am a associate professor of sarcoma medical oncology at MD Anderson here in Houston. Welcome to all of you to sunny Texas. You may think it's hot outside, but it's way better than it was 2 weeks ago. So, we're going to be talking about three post hoc analyses from the DeFi trial, and I think, I think it's special for us to be able to do that. This group and DTRF were really instrumental in making that study happen, driving patients to it, supporting patients through it, and I think as we learn more and more from these studies, I think being able to bring that back to this community is a gift in itself. So, and thanks for giving us the time. These are my disclosures. As this audience likely knows, the DeFi study was a phase 3 study of nirogacestat versus placebo in adult patients with resist progressive desmoid tumor. Patients, 142 of them, were randomized from May of 2019 to August of 2020 to receive either nirogacestat or placebo, and the study was run internationally here in North America, Canada, and Europe. So the crux of this analysis is trying to understand the impact of pain on physical functioning. As this group knows well, pain is one of the most commonly reported symptoms in patients with desmoid tumors, and pain may then lead to downstream effects on function and mobility. And so for a lot of patients, the reason that we treat, and indeed a key goal of treatment, is to reduce pain. So this analysis looks to determine whether in those patients that have a clinically significant decrease in their pain on treatment, is that pain then relief then associated with an improvement in functional domains? And so that's what we're going to be talking about today. The DeFi study used a number of different PRO instruments to assess both pain and changes in physical function. So when we're exploring this association, we're going to be using the BPI short form, 1 to 10, how bad was your pain in the past 24 hours? Patients were asked to respond to that question daily for 7 days prior to each cycle, and the worst score was used. And then we're going to see if that's associated with an improvement in multiple indexes that look at physical function and quality of life. So these are the BPI, short form pain interference index, which was highly correlated with patients who had improved pain. There's the GODDESS DTIS physical functioning domain, which was moderately correlated with improvements in pain on the BPI short form. There's the EORTC QLQ C30 role functioning instrument, which was again moderately correlated, and the EORTC QLQ C30 physical functioning instrument, which was only weakly correlated with improvements in pain on that BPI short form. So the next thing we're going to do is actually look at the specific questions that were asked and the specific domains that improved in patients that had clinically significant improvements in their pain. So the first instrument we're going to look at is the BPI pain interference index, and it asks patients about improvements in multiple different domains. And we're going to look at these different instruments, and each of them is a different scale, which gets confusing. So this is a 0 to 10 scale, okay? And what we see is that patients reported that their sleep in general was 4 points better in those patients that had a meaningful reduction in their pain. Enjoyment of life, normal work, mood, general activity, relationships with other people, and walking ability were also all improved by about 3 ordinal points on that 10-point scale. Sleep seemed to be the big one. In the GODDESS DTIS physical functioning scale, a different set of questions and a different scale. Now, this is a 1 to 5 Likert scale, so it's not 10, it's 5 now. And here, movement near the tumor was improved by 1.7, and you can see doing vigorous activities, moderate activities, accomplishing less than one would like, were all sort of improved by about 1 point on that 5-point scale. Finally, the EORTC QLQ C30 survey here, this is a 1 to 4 scale. So not 1 to 5, not 1 to 10. So these are not numbers that you can go back and forth with. You can see that patients reported that they were able to take a long walk about 1 category better on the 1 to 4 scale, with the other things only minorly improved, but recognize that this was a moderate correlation. And then finally, the EORTC QLQ C30, items seem to improve by 1 category on the 1 to 4 scale, pursuing hobbies and leisure activities and doing work or other daily activities. But this was the scale that was only weakly correlated with an improvement in pain. So I think the summary of this post hoc analysis is that, is there a relationship between pain and physical functioning? We see moderate to high correlations in 3 of the 4 instruments that were looked at, and only a minor correlation in the fourth. The way in which pain improves physical functioning varies, but seems to improve in domains as diverse as sleep, being able to function physically and perform roles. And I think that's presentation number 1.